Hello, everyone. This is Kevin Roth from Lehigh Valley Health Network, and I'd like to introduce you to Buzz. She's going to help me describe a diagnostic algorithm with point-of-care ultrasound called Be First in Dyspnea. But first, our dream sequence. You're heading into work. It's a beautiful day, bright blue sky, puffy white clouds. You head into the ER. It's nice and shiny and clean in the morning, and it actually smells kind of good today. But our friends, the paramedics, are bringing us a patient. This is Unit 8993. We are bringing a patient with severe respiratory distress. And here she is. As the medics bring her past the desk, they say, "Looks bad, doc. IVO2 monitor, physical exam, what's next?" That's right, Buzz. Don't get stung. Be first in dyspnea. Use point-of-care ultrasound. Why be first? Those that use point-of-care ultrasound understand that there's many building blocks of applications at our disposal. What Be First does is organizes them and putting them into a package that is repeatable and recognizable. It crystallizes knowledge that we've had for some time and puts it into a package that's easily accessible. Why Be First? It's a systematic algorithm in times of stress. We want to recall things easily when somebody really is ill. Finds causes that require immediate care. They can't wait. Timely pathology identification, which overall improves time to treatment and patient disposition. But truly, why Be First? Because if we assign a post-it note of a certain diagnostic algorithm that we want to go through, and we're incorrect, the diagnosis and then the subsequent outcome of that patient could be jeopardized. We work with incomplete information, and point-of-care ultrasound gives us a lot of quick and accurate information. Here's Be First in dyspnea. B lines, effusions, ejection fraction, IVC, infection, infarct, right heart strain, sliding lungs, and thrombosis and tumor. Be careful. Point-of-care ultrasound has to be combined with the patient's presentation and their physical exam findings. I'm going to show you images today that look very similar, but they mean completely different things. So putting it in context is important. Here's our scanning protocol for Be First. What we do is first, we actually look at the patient's lungs anteriorly, and we start from the apex and we work our way down the costophrenic angle bilaterally. If the patient can sit up, we'll perform the same thing posteriorly from the apex to the costophrenic angle posteriorly. So what are we doing? We're really trying to interrogate each lobe of the lung. Overall, some patients cannot sit up, so we may have to actually put our transducer close to the bed to get those more posterior aspects. And finally, we perform an echo. Let's talk about transducers. There's three main transducers we use in Be First. The first is the linear array. High frequency probe is great for looking at the pleura and obviously looking at vessels. The phased array starts with this tiny footprint and spreads out. So it's nice in children and it's nice to get in between ribs. So it's really nice for echo. We can utilize it for lung and IVC. And then finally the curved array, it's a little bit deeper penetration and it's great for the IVC, and of course we can use it for lung. So let's start. Be First in dyspnea, B lines. To explain B lines, we first have to talk about A lines. So here's our phased array. We're looking at the right lower lobe. And as this person's inspiring, we're seeing the right lower lobe, but we're also seeing their kidney and an image of their liver. And what you're seeing are a couple of things. You're seeing the bright white pleural line. Above that is soft tissue. And you'll notice that that bright white pleural line is moving almost like marching ants, like you saw when you were a child, those ants marching back and forth from an anthill, just swarming back and forth. So that's sliding lung. And then finally, we see these lines that are hyperechoic in the horizontal plane. Those are called A lines, and they are a reverberation artifact from the pleural line. This is a similar image utilizing the linear array. We're seeing the bright white pleural line, we're seeing the sliding lung or marching ants, and then we're seeing our A lines in the horizontal plane. Here's usually using a phased array, and we're seeing B lines. In the vertical plane, this is abnormal. I want you to note as well, at the very top of the screen, we've got soft tissue, then we've got that bright white pleural line, and again, it's sliding back and forth, but we're also noting that the bright white pleural line is smooth in the transition between it and the B lines. But again, B lines in the vertical plane are abnormal. B lines means that there's some interstitial thickening. So this is an artifact that is showing us this interstitial thickening. Now, there may be more than one reason for interstitial thickening, and we'll talk about that. But overall, it's typically inflammation or edema. Here's the linear array looking at some B lines. So on our left-hand panel, we're seeing our B lines, and then we're seeing the pleura, and it's relatively smooth. On our right-hand panel, we can look at the pleura, and it's irregular at the base of those B lines. So this is one of our patients on the left-hand panel. There's B lines, smooth transition, abnormal, congestive heart failure. On the right-hand panel, there's like dents. That's abnormal. It's a patient with COVID. So let's sum up B lines. A lines are in the horizontal plane and they're normal. B lines in the vertical plane, they are abnormal. So how do we use that clinically? So if I'm concerned about congestive heart failure, the presentation is consistent with that. It's early diuresis. I don't wait for chest x-rays. I don't wait for pro-BNPs or their creatinine. They get diuretics. If I'm more concerned about an infectious process, such as COVID, I'll isolate and treat them appropriately, specifically if they have dented or irregular pleura. Now, of course, you could have smooth pleura. It could still be inflammatory with an infectious process, but sometimes it's hiding some findings deeper in the lung. And then pulmonary fibrosis, typically it's chronic, but you could also see this in a patient with developing ARDS. And then finally, another common reason for B lines are pulmonary contusions in the face of trauma. Here's a little bit of honey from Buzz. It's called simple scanning. It's another mnemonic, but what it means is this: sonography mixed physical exam. So to be clear, physical exam findings are completely different than point-of-care ultrasound. Point-of-care ultrasound is a procedure. But this little bit of honey from Buzz is taking your physical exam and mixing it with sonography. So you put the probe where you find tenderness. So that trauma patient, if they had blunt trauma to the right lateral aspect of their chest, I would put the transducer right there. If you see B lines right there, it's consistent with their pulmonary contusion. They have rails. Put the transducer right there. Muffled heart sounds, decreased breath sounds, murmurs. Put the probe where you have a physical exam finding. Let's talk about effusions. So to talk about effusions, I want to introduce the parasternal long axis view of the heart. This is a normal parasternal long axis view of the heart with a phased array. And I'm going to label the anatomy. So the very top chamber you're seeing is the right ventricular outflow tract, or the RV. You have the septum, you have the left ventricle, the left atria, the aortic outflow tract. Now, an important marker is to find the descending aorta. You want to be deep enough that you can see the descending aorta, and we'll talk about that a little bit more here in a moment. You're seeing the aortic valve, you're seeing the anterior mitral leaflet, and you're also seeing the left lung. So when you're talking about effusions, finding the descending aorta is important. Because if there's something superficial that's hypoechoic to descending aorta, that's a pericardial effusion. You can see the hyperechoic pericardium. If it's deep to descending aorta, it's the left lung, and that would be an effusion. So here's a patient. The arrows are pointing out this circumferential pericardial effusion, and you can see it's superficial to descending aorta. But in addition, this patient also has a hypoechoic collection deep to descending aorta, a pleural effusion. Here's a second patient. Descending aorta is identified. The bright white or hyperechoic pericardium does not seem to have a fluid collection. As opposed to deep to descending aorta, there is a pleural effusion. Now, of course, this is one of those cases where we need to take immediate action. This is tamponade. So yes, there's a large hypoechoic area, but doesn't it look like somebody's jumping up and down on the free wall of the ventricle, right ventricle there, as if they're on a trampoline? That would be tamponade. Thanks, Buzz. And of course, those that use point-of-care ultrasound understand that it is a powerful tool when you're talking about aiding in procedural guidance, so we can aspirate that effusion. Now, changing to the curved array, we can also identify large pleural effusions that can cause dyspnea. So in this case, we're seeing the liver, the diaphragm, a little glimpse of the kidney, but overall this large hypoechoic area of effusion. And what you'll see on this live image is you'll actually see something called the jellyfish sign. So that large pleural effusion is compressing this lung and causing compressive atelectasis and making the patient dyspneic. So effusions. Pericardial, is it tamponade? Then we need to act quickly. Is it pleural and compressive? Again, they may need to have their lung aspirated. And then finally, is it both? The additive effect of having maybe not the largest pericardial effusion, but combining that with a large pleural effusion can certainly add in their dyspnea. B first in dyspnea, ejection fraction. So let's go back to our base normal echo. And what we're seeing here is the LV, the septum, and the LA. And I'm also pointing to the anterior mitral leaflet and its excursion. So there's really four things that we look at to estimate if the ejection fraction is normal. Because as acute care physicians, typically we don't really need the exact number. We need to know, is the EF normal or is the EF abnormal? In this case, it's normal, and here's why. The first is the anterior mitral leaflet excursion. Does the distal aspect of that strike the septum or come quite close? It does. If we look at the walls of the LV, they are shortening and they're thickening. Another good sign that the ejection fraction is normal. And then finally, what's the change in the size of the LV's chamber? If it's significant, again, you can add that with these other findings, and you've got a normal ejection fraction. As opposed to this patient has a decreased ejection fraction. So all those conditions we just spoke about are violated. First, the anterior mitral leaflet really gets nowhere near the septum. The walls do not get thicker, they do not get fatter, and the change in the size of the LV is minimal. And then this patient, I think, reinforces the fact that this person's not having a good ejection fraction. There's very little blood pumping with each contraction. So ejection fraction. Decreased EF, plus or minus B lines, history consistent with early diuresis. Again, no creatinines, no pro-BNPs, diuretic. Normal, we can question whether there's diastolic dysfunction. Now, it's a little outside the scope of this lecture, but it's something to keep in mind. B first in dyspnea, IVC, infection, infarct. So let's talk about IVC. It's a helpful tool to kind of confirm some other findings you'll see with B first. So here is our IVC as it's entering the right atria. This is a longitudinal view. And what we'd like to do is we measure approximately 2 centimeters from the right atrium. Now, we can also measure using M mode. And what we can do is we can capture inspiratory change during that period of time. So you have to coach your patient. You have a maximum diameter, but then you have to coach them to sniff, take a quick sniff, and actually get the inspiratory change. It's not perfect. There's other things that cause enlarged IVCs, but overall, when you're talking about fluids, a study had been done actually looking at the numbers I like to look at are 1.5 and 2.5. So less than 1.5, their CVP is probably low. Greater than 2.5, their CVP is probably high, and then there's ranges in between. So do I measure every patient? Really not. Overall, what I do is I'm looking for respiratory variation. So somewhere in the middle is what our goal is. So they may be somewhat euvolemic. As opposed to if there's total collapse of the IVC, the walls are kissing, their CVP is low. And then finally, if it's really large, plethoric, and there is no respiratory variation, of course, that would vote that their CVP pressure is high. So IVC. If your IVC diameter is increased, and specifically if it's increased and you have a decreased ejection fraction in B lines, that's the big three for CHF. I would definitely hit them hard with diuretics, maybe a nitro drip, or whatever other strategy you have. Cardiac tamponade, yes, if you've got an effusion and you have increased IVC diameter, I would be concerned that it's truly tamponade. And then pulmonary embolus, do you have a right-sided increased pressure? Yes, your IVC could be enlarged with a pulmonary embolus. We'll talk about that a little bit more. Infection. So we spoke about B lines. We spoke about B lines with COVID, but remember, you can have B lines when it's also another infectious process. There may be something deeper that you can't see because of this artifact. Overall, in this next view, what you're seeing is you are seeing some B lines, peripneumonic B lines, and specifically this is at the pleura, and you can see this hypoechoic area. It does have some internal echo, so it's not an effusion, and you can see how there's an irregular nature to it. This is called the shred sign, and this is a subpleural consolidation. You will not see this on chest x-ray. You can see it on CAT scan, and you can see it on ultrasound. And then finally, another infectious finding that you can have with lung ultrasound. In this case, you're seeing an effusion, but then you're seeing lung. They call this hepatization or the tissue sign, and this is with a lobar pneumonia. Now, I will say you would see this on chest x-ray, but you can find it very quickly with bedside ultrasound. The other finding you're seeing, and this person's in significant respiratory distress, you can see these hyperechoic railroad tracks, and they really mimic air bronchograms. So infection. Inflammation, is it COVID? Is it more peripneumonic? Shred sign, is it a subpleural consolidation? And then finally, hepatization or the tissue sign for a lobar pneumonia. Infarct. I like speaking about wall motion abnormalities. That's not the infarct I'm speaking about today. Next time we'll talk about that. The infarct today is a pulmonary infarct. Again, this looks quite similar to what you may have seen earlier with the shred sign. This is an enhanced view. It's at the pleura, it's hypoechoic, but one thing to note is there are really no peripneumonic changes. There's no B lines around this pulmonary infarct. So infarct. If it's a pulmonary infarct, is there right heart strain? Again, we'll speak about that in a moment. Enlarged IVC, again, is there a PE? And then finally, the shred sign versus infarct. Remember, nothing's universal, but if they do have more of an infectious process, there's a chance that there's inflammation and B lines surrounding the shred sign as opposed to infarct. Right heart strain. So back to our parasternal long axis, there's a lot of ways to look at right heart failure. But overall, the rule of thirds talks about right heart enlargement. So when we look at the parasternal long axis view, the right ventricle, aortic outflow, and the LA all should be approximately a third, a third, and a third. So back to our normal echo, we've got our RV, our aortic outflow, and our LA. So if you look at these as far as distance, this distance, this distance, and this distance, all are approximately the same. As opposed to this patient, if we look at the RV, the aortic outflow, and the LA, the RV is much larger. Quite honestly, it appears to be approaching the size of the LV. This patient had a saddle embolus. Looking at it more closely, the other thing you'll see is that there's actually septal bowing. So there's enough pressure in the right heart that it's pushing the septum into the LV. Now I know I speak a lot about the parasternal long axis view, but if we turn the transducer 90 degrees and get the parasternal short axis view, in this case we can see that board question and answer, the D sign, where you can see that septum flattening. And then finally, for completeness sake, the 4-chamber apical view. And I have it labeled for you, and you'd say, well, what's the big deal? I can see that there's a very thickened wall of the left ventricle, so that is obvious what the anatomy is. But sometimes it's not as easy. Sometimes the LV can be thin-walled, and it's difficult to judge. So, of course, pro-positioning is important, but if I take away these markers, the two things I want you to look at is, first of all, look how big that RV is. So certainly there's increased right heart pressure. But also, if we look at the seating of the tricuspid and the mitral valves, you can see that they're a little bit different. The mitral valve is a little bit more toward the base. So without congenital heart disease, there's a good chance this would identify your anatomy for you, the mitral valve being closer to the base. Right heart strain. Increased right heart size, plus symptoms and vitals, prompt CT and treatment. So overall, we've actually thrombolyzed patients off of our point-of-care ultrasound, not waiting for CAT scan, as these patients were unstable. Now remember, you can also look at pulmonary infarct. Do you have that? Is the IVC enlarged? Things along those lines to concrete this diagnosis. Sliding lungs. So is their lung sliding? Do they have a pneumothorax? So this side-by-side comparison of a patient, the left-hand panel is showing you those nice marching ants, sliding lung. This is all soft tissue coming down to that bright white pleural line. As opposed to our right-hand panel, no lung sliding, pneumothorax. Now, this slide's been reproduced by many as it's so well done, but M mode confirmation. So on the left-hand panel, you've got M mode showing the chest wall and musculature, and there's no movement, so you have these lines that are in the horizontal plane. But there's movement within the chest at the pleura specifically, so you've got this more sand on a beach or scatter effect. No pneumothorax if we see sand on the beach. As opposed to the right-hand panel, you're seeing barcode on top, these horizontal lines in the chest wall, but then you've got these horizontal lines within the pleura or chest. So barcode on top, barcode on bottom, pneumothorax, no movement. So to reinforce that, this is the linear array view of the pleura, and you can see the lung sliding. We put our M mode cursor as perpendicular as we possibly can, and we turn on M mode. And you're seeing soft tissue at the top, and you're seeing the sand on the beach on the bottom. And then finally, on the side where there's a pneumothorax, we put our M mode cursor, and it looks like the chest wall is moving, but not the lung itself. And turning on M mode, we've got barcode on top, barcode on bottom. So sliding lung. Pneumothorax, there's no lung sliding, M mode's abnormal, it's time to act. And then finally, thrombosis and tumor. So back to our base normal echo, nice clear chambers. But in this patient that presented with dyspnea, they actually have a left atrial myxoma. Just to show a second view of that, this is a 4-chamber apical view. But again, hyperechoic and smooth myxoma. As opposed to this patient who presented with a right atrial clot, you're actually seeing it's irregular in its appearance, and it's very mobile, trying to get through the tricuspid valve there. And then one more left atrial clot. Again, trying to sneak through the mitral valve there. Irregular and mobile. Now, a quick bonus. We talked about lung ultrasound and performing an echo, but we also, with thrombosis, have the added ability to look for deep vein thrombosis. So the mainstays of this, looking at the femoral artery and the femoral vein, is compressibility. You can see the vein going away with compression, and that there's color flow, which if we squeeze downstream, we could also augment the flow to that vessel. As opposed to this, there's no flow and there's no compressibility. Take my word for it, we're trying to compress this vessel. Thrombosis tumor. Intracardiac mass, irregular and mobile, thrombus. Smooth and fixed tumor. Now you may say, that seems pretty rare to me. Well, I have the opportunity, I'm blessed with 50 plus residents and 80 plus attendings. So they do enough echo that this is much more common than you would think. And of course, bonus, DVT. If we can add that to the rest of the information we have, it can send us quickly to a diagnosis. So here we go. B first, fast answers. Echo the phased array. Is there tamponade? It's time to act right now. Decreased EF, increased RV. Is there a mass? And in the IVC for supportive information. Lung the phased array. Are there B lines? Is there a pleural effusion? Is there a pneumonia? Then lung the linear array. Is there a pneumothorax? Do they have pleural disease or an infarct? So if all of these are negative, COPD or asthma, submassive PE, you may need to go on to further testing. And then the other things that can cause it is valvular pathology or diastolic dysfunction. Now, while I do speak about those, they exceed the scope of this particular lecture. Questions, comments, or ideas? I'd like to thank Buzz for her help and I'd like to thank you for your attention. See you soon.